So, good evening, everyone. Welcome to the Washington State chapter of HIMSS. And today's event, we're going to be focusing on a discussion that our presenter Sri will be presenting, which is on the topic of crisis as a catalyst for change. And on behalf of our Washington chapter, myself, Joanna Valderrama, and our president, Dwayne Neufeld, would like to welcome you to our event. We try to have an event every month, every fourth Thursday of the month. So if ever you're interested in joining us for future ones, please do. Our agenda today is to introduce you to Sri. He's the Vice President of Digital Innovation and Application at Franciscan Alliance in, I believe, Indianapolis, and you have a location in Illinois as well. We'll have a quick Q&A session, so in case you have any questions for Sri regarding his topic today. Then at the end, we'll have a quick survey. We like to take surveys on our events just so that we can provide better and improved events for the future for you, just so you can have more value as a member of our chapter. And our next event is planned for February 24th next year. And I'll provide more details on that in the next slides. So for those of you who aren't aware, HIMSS, which stands for Healthcare Information and Management System Society, we're a nonprofit global organization, and our goal is to be a global thought leadership on things such as advanced networking, consulting, all related to the health ecosystem and how it's impacted through information and technology. And the vision is to realize the full health potential of every human everywhere. And our mission is, again, as I mentioned, to reform the global health ecosystem through the power of information and technology. So if that's something that really interests you and that you'd like to reach out to us for more resources, events, networking, just to be in the know of what's going on in healthcare IT, I encourage you to join HIMSS. And we have our link there at the bottom of this slide. As I mentioned, we are a nonprofit organization, so we rely heavily on the generosity of our sponsors. So these are just some of the different tiered sponsors that assist us through our board. And so let's meet our speaker for today. His name is Sri Bharadwaj. He is, as I mentioned, Vice President of Digital Innovation and Applications at Franciscan Health. He has over 25 years of information management systems expertise. He's been in leadership roles in various provider organizations and various health plans throughout the years. He's a well-known speaker, and you can find more information about him on his LinkedIn page, and we have his link there. This will be recorded, so if ever you need to refer back to the information that's being presented today, we will provide a link to our YouTube. All right. So again, a little bit about today's event. We will be hearing from Sri how the pandemic has led Franciscan Alliance's provider community and patient community to innovate for the future. We're also going to learn about hospital at home programs, which essentially allow inpatients to be treated from the comfort of their own home. So we ask you today, as Sri goes through his slides and his content, keep on top of your head these particular two statements that he mentioned in a previous presentation and that is our next generation is going to receive care where they are, despite of, they can, as I mentioned earlier, they can be an inpatient, but they're from the comfort of their home. So, and also think about no care settings, no transitions, no data withholding. So think about these two phrases, these two statements as Sri goes through his slides, and think about some questions that you might want to ask at the end of the presentation. So again, welcome, and I'll go ahead and have Sri start his presentation.
You guys see me?
Yes.
Perfect. And I'm going to share my presentation. Is it good? Joanna, is it good?
Yes, we can see your slide.
Okay, awesome. Thank you.
Thank you.
Today we're going to talk about how we are going to take the pandemic and figure out how did we as an industry uh, change through the process, but also became a catalyst for innovation. So when we talk about innovation, we always struggle with various things that we kind of go through on a normal day-to-day basis. What we wanted to make sure is that we can help understand how we could take this time frame in what we went through and figure out how did we take and how do we do things differently in healthcare to become that catalyst? How do we take the crisis and convert that to a catalyst to make it better for us going forward? Um, if you look at the where we are today, we spend quite some time on virtual care delivery, right? I mean, we talked about how we have to get more patients to be seen virtually by our physicians. The the other pieces that we found was that we got a need for rapid clinical decision making as well as part of this process. So that is also something that we realized that we needed to get done. And then, of course, resilient workflows, right? So we want to make sure that the workflows were resilient enough that we would be able to take care of patients at the same time. That is from our perspective what we felt as a organization as well as a capability that we delivered to our patients across the board. Thinking about many of you guys have seen this, a digital hype cycle in 2020, and we'll talk about 2021. What many of you would have seen what a Gartner hype cycle is, right? It starts with innovation triggers. It goes through the peak of inflated expectations. You look at the trough of disillusionment, and then a slope of enlightenment, where you kind of get to a point where you look to a plateau of productivity. This kind of cycle that we have seen over the course of the years had the remote patient monitoring at the far end of what we were looking at doing in virtual care. Now, if you look at what happened in 2021, it kind of transformed the environment, right? We moved all of this stuff over. We started bringing in the ability for process simulation modeling, autonomous monitoring, right? We want to get through the next generation nurse call. This is how we transition from just within 1 year. So if you do the comparison between those two, you can see how all of those features, functions that we pulled together kind of translated into what we got here on the right-hand side, just within a matter of a year. That's how fast we changed. That's how fast we transformed ourselves. And that's how fast we delivered better capabilities for our patients. And if you look at talk about what do you mean by virtual health? Because a lot of people, different people are different meaning around virtual health. When you look at, it connects clinicians, connects patients, it connects families and their care teams, and of course, other healthcare professionals to provide health services, right? I mean, think about it. That's the overall scenario. But it also promotes collaboration. It promotes some level of self-management because you have to be taking care of yourself as part of this process. And also you have to coordinate care across the care continuum. That's the next piece that we typically go through, right? If you take the longitudinal care continuum of a patient, all of these activities happen during the course of the period of time of a life of a patient. But virtual health was just one portion of it that brought together everything else while making sure that we've got the collaboration that is required. Much of this stuff did not happen before. What happened before was we would go to a physician, get care, be seen, go to the pharmacy, get medications, take medications, feel better. Otherwise, go back into the system. That's what we typically have been doing. What happened? All of that changed because we, number one, could not see our physician when we wanted because the physicians were unable to see us. The second thing is we were kind of broken out within families because we could not see each other from a family perspective. And for health professionals, we could not be able to do anything that makes sense. So we figured that all of this entire virtual health kind of created a need to innovate. How do we do things better without modifying a lot of stuff that we do, but making sure we got the best outcomes at the same time? This is your typical capability, right? We got prevention, diagnosis, treatment, and home care. That's what happened with virtual care. This is what truly really occurred in the process, and this was continuous, right? We would have home care, we would get the prevention capabilities, we would get the diagnosis, and we would get the treatment. Again, if you fell sick, you go through the same process. Only thing is, all of this done was now being done virtually. Thinking about where care happens and thinking about care at home, to that matter, you're looking at bringing the care and providing access to where the people want it. Like I had talked about, if you take where we are today, you have care settings, right? You have care settings where you have the hospital, brick and mortar, large scale setting. You have the ambulatory, which is your typical primary care or specialty consults that you go to every day. And then you also have obviously a lab, a radiology, a pharmacy that you go pick up medications. And then you also have a SNF, which is your skilled nursing facility. And then you have home health. You take all of them pulled together. Many of these functions are connected by the patient visiting them in several aspects, right? Think about a situation where you are no longer visiting them. You become part of the community. So we want to provide access to care to the people where the people want it. So you have to look at the living well in the community. You have to maintain your health being the part of the primary care, which is what it's focused on. You have to look at community rehab. How do we get the support and equipment to keep you at home? Enhanced care, right? Where you got need for us to get additional care because your existing care is not going to support you. And then the ability for you to have a specialist acute care treatment, which is where in a hospital home type situation. We'll talk that a little bit more. Now, if you take this as a cyclical process, right? When you look at direct to consumer, you're looking at a consumer care model. You look at it direct to patient, you're getting a patient care business model. You're looking at remote patient monitoring offers a chronic care business model. Complex care management and hospital at home. Hospital at home offers that tier of service that we're looking at acute care business model where you really need that capability. This is depending on the severity of illness, as you see in the bottom. The healthcare consumer transcends from each of these up to the right hand side corner. Of course, it all has to be digital, right? So from our perspective, we see that the digital front door becomes a critical component of how we actually engage with the customer, what they do with the customer as part of that process, and how we deliver that information to them to achieve their health goals. On the other hand side, you can't get a digital front door if you don't engage from there where they are in terms of how they bring in the data that is coming from them. Your Apple Watch, your Fitbits, any of that stuff has to bring in that data over. So that talks about the ability for you to look at patient generated health data. You got to bring that ability to bring the data in to understand the full picture of the patient. Then you look at the IoT platform type environments where you got the connected care platforms, a platform that has got a combination of a pulse ox, a blood pressure cuff, uh, um, a thermometer, a weighing scale, a glucometer, all put together as part of a bundle, which is all connected in some way, shape, or form, offering a connected care platform that the physician can have access to. So you give the connected care tools to the patient, to the physician on the other hand side, to take a look at what's happening on the data that's being received from the connected care platforms. Then you're looking at healthcare consumer data platform. So this is where you are looking at a comprehensive ability for you to take the digital front door, the consumer patient generated data, the connected care platform, put it all together in a platform that can be used to trigger activities with the customers, so you make it work. Remember, I changed from saying patients to customers, because now what's happening is it is now no longer a patient, because the patient could get better by doing those three things, but ultimately become a customer. So you got to keep this going forward. A combination of all of these services will offer the monitoring, diagnosis, and treatment that is in your digital products and services platform. So a comprehensive platform that really helps you build this moving forward. Switching to hospital at home. So what is hospital at home? I don't know if you know, the hospital at home is not a new concept. I mean, it's been around for decades. Many years ago, we used to have physicians walking, seeing patients in their homes, performing surgeries in their homes, if using crude utensils that they had in their hands, and many respects, the patient stayed at home recuperating and never went to a. There was another situation called a hospital. They went to a hospital type location where only when they had to really get acute care. Otherwise, most of the time, the physician actually saw the patient in the house. Guess what's happening? That's exactly where we're going back. It's a combination of capabilities that we've got now, that we can take some of the tools, technologies, capabilities, build it in the patient's home, and offer that capability in the patient's home. And guess what? We found out that the patient gets better if they are taking care of themselves in their own hospital settings. When we talked to some of those folks, we got feedback from our patients saying, "Oh my God, I don't have to eat hospital food anymore. I can make the food I want at home, and my daughter can give it to me." Think about it. That's a simple thing that you're talking about, but it's a big patient satisfier from what they see. They also don't have the need to get to hospital acquired conditions, right? Clapsy, CARI, sepsis, all of that stuff that typically you get when you get into the hospital is something you can avoid looking at hospital at home as a capability. So what are we talking about here? When you look at the home-based care models, and what you could see on the left-hand side is the paid, unpaid personal care that you have in the bottom, right? And then on the right, as you move towards the hospital at home, which is more a situation where you're delivering home-based primary care to hospital at home care, where your acuity is going up, as well as the ability for care going up, your community paramedicine, your rehabilitation at home, your transitional care, all of those taking a step up depending on the acuity. And only when necessary, you're moving from that hospital at home environment to a acute hospital environment. So it's a transition only for very high acute, almost close to, I have an ICU patient that I cannot treat at home, then I'm going to bring him to the hospital. Otherwise, the patient just stay at home. That is the kind of model that we're looking at. That is the kind of model we are talking about here. However, having said that, it's great to have those technologies and make it work. But look at the complexity we have around surrounding a patient. Look at the social determinants of health, the psychosocial capabilities, the behavioral capabilities that you need, the governmental funding associated with how we're going to get paid from various situations, transport, right? If I need to move the patient back and forth, where is the transport coming from? Employment, those factor into, can I take 10 days off and stay at home and get care for, and be part of that process, be part of hospital at home. Political, right? There's a lot of, especially with healthcare, right? There's a lot of political structure, power groups that play in the healthcare environment from a political perspective. Education, depending on the patient levels education, how is he going to use the solution? What capabilities we got? What situation he can truly understand how these devices work and so on. Economy, right? Huge factor in how we look at those incomes, wealth, poverty, depending on where they are in the social spectrum of care, social spectrum of life. All of that takes into consideration. Of course, air quality, a big, huge factor. Housing, right? I mean, it also depends on the other environmental factors, and of course, the medical aspect of it. So if you look at the entire complex situation of how you look at a patient, these are all some of the factors that the framework that we can get together on. So when we talk about virtual care, you're looking at advanced care at home. When you're looking at advanced care at home, you're talking about a virtual hospital structure. So for example, we run Epic in our environment. So you can actually discharge a patient from the acute hospital inpatient setting to a virtual hospital at home setting directly from Epic. It's a great way to move, from a bed to a virtual bed, kind of think about it that way. And then when you move that patient to a virtual bed, how is that? How does that truly occur? You need all of those telemetry that was delivering your data in a different form. Now that information is going to come from your patient. So that information is sent to with the patient home. Now the patient is then taking those devices around him, sending that information back into our Epic to make sure that that information that we need, critical information that we need to take care of the patient, is available, and then transforming that into a situation where you're creating a virtual hospital type setting where you flick of a button, you got the phone, you can talk to a nurse. A flick of a button, you can do a video visit. Look at what's happening with their medication, so they take the medications accurately. You got a 3-visit process. The hospital home waiver, we got a hospital home waiver at CMS. We got a 3-visit process. One is in the morning, you go, you send a paramedic to make sure that everything is fine, whatever. You have a virtual visit with the nurse and another virtual visit with the nurse if you need, and almost once in 2 days have a physician visit as well as part of this process. So it's a very structured combination of capabilities that you are delivering in a home-based care, which brings in all of those services. Now, looking at labs imaging, there is so many capabilities that you can get through to labs today. I can do an ultrasound directly in the patient's home by giving him an equipment that makes sense for us. There is, as long as you have the right help you need, keeping the patients home, getting the patients better in their home setting is what many patients prefer, purely because they feel that they are at home in their place to make sure that they can get better. They don't, and of course, they have the help that they need to get this done. I had a patient whose daughter said, you know what, I know that she's getting better. I'd prefer to keep at home, and I'll bring her back in case she struggles with anything. She took the patient home. She would have kept typically been in the hospital for about 4 to 5 days. When she got home, she got better in 2 days, 2.5 days. A COVID patient. Yes, there was this, requirement for, the 14-day and all of that stuff, and we understood that. But the fact that the patient went home 2 days earlier got us another bed for another patient who was highly acute. That is where the benefit of doing advanced care at home through a hospital home situation helps. Do we have the virtual capabilities? Yes, we do. We've got the digital assets that healthcare providers use. So for example, we've got a Bluetooth stethoscope we've used. We've got a ultrasound that we've used. We've got, of course, thermometer, weigh scale, all of that stuff we use. We actually have you can get a hospital bed in the house fairly easily because you can get that through DME and make that available for the patient so that you can see what's going on. And you can do telesitter today from wherever the nurse is in the patient's home, as long as you can pipe the video directly from the camera that we've got directly into Epic that can be seen. So we have all of these digital capabilities today to move the needle, to get stuff done and keep it going. That is where we see the ability for us to transition from where we are today from a healthcare perspective to what we think we would need going forward. Now, there are social, financial, regulatory drivers, right? I mean, think about it. We've accelerated the virtual care capability in 12 months. Why would we not accelerate the same capabilities for hospital at home as well in the same period of time? So we did have a conversation with the CMMI director, and we were told that there was going to be, based on what they've done around the innovation, pilots that they've done, they seem to think that the reimbursement capabilities will continue to stay for the near future, depending on what happens with everything else that's happening around COVID. But they are looking at this to be a long-term position for us as the industry. So there are several best practice examples we can take you through. One of them is Geisinger Home Care. They've got 5,000 enrolled patients. They've seen a 35% drop in ED visits, 40% drop in hospital admissions. I mean, it's look at the reduction in spend. This is the kind of thing that really helps us move the needle for healthcare. So that is phenomenal. And there are a lot more data nowadays. I mean, this is about close to about 6 to 8 months old. There is plenty more data available. There's actually a website for hospital at home user groups. There's a hospital at home groups that you can take a look at. We are all members of that. There are several organizations that are doing that today, HAH user groups. So now if you look at what do we need to do from a community and social care services, how do we bring that together? Because that's how people get better, right? You can't, the many times what we have seen is that you bring the community together, you bring the people together that they are familiar with, they get better. So how do we bring that all together? How do we make it work? So we have a kind of framework on how that will work as well for us. Of course, there's an eye chart, but if you look at population care, population health, the experience of care, the per capita cost of what it is, you should look at the patient care team experience and research challenges, a phenomenal way to help people understand what are all some of the factors that we need to consider as part of hospital at home as well. What we have done, and just to give you a bit of a background, what we have done is we have spent quite some time interviewing several organizations that are in the middle of doing a hospital at home type of situation. When we looked at it, we said, okay, so how do we? I mean, I belong to the innovation committee, so the HIMSS innovation committee, and we spent quite some time this year interviewing several folks who have been at the forefront of hospital at home and how this makes sense. And we've got some great feedback from a lot of people around how this has been working effectively for them, not only working effectively for them, but also how they see this as a path toward the future. So when Joanna talked about the fact that we have all these care settings, right? Think about it, we have so much interoperability between those care settings. Data has to move back and forth. We miss data in between. So for example, patient leaves the hospital, goes to nursing home. Is the data coming back to the physician to see it? Maybe, maybe not. When the patient leaves the nursing home, goes to home health, is that data going back to the nursing home or going back to the hospital? Maybe, maybe not. Is the data going back to the PCP who is seeing the patient as well? Maybe, maybe not. So what we did in Franciscan is we created what we call pods. So in our model, if you take the patient in the middle, you surround them with a series of a pulmonologist, a cardiologist, an intensivist, a hospitalist, a nutritionist, the PCP, a nurse, as well as the caregivers for the patient. So bring them all together. You share the data along with them in that platform so everybody can see what's happening with the patient. And you have in and out, of course, people coming in and out of the process, but at the same time taking care of look at what's happening with the patient all around them. That kind of model truly helps the patient improve much faster, because in an acute care setting you always struggle with, when am I going to go home? Think about it. That's what the patient is thinking about. When am I going to go home? In the case of a hospital at home, he's home. He's in his most comfortable surrounding. He's in the best possible situation that he could be in. But at the same time, he's getting the best care possible. So that is where the difference lies in. No more data moving back and forth, no more care transition. I'm not moving from a patient from an ambulatory, I'm going to go see a physician, I'm going to see a surgeon, I'm going to see somebody. Yes, I have to go get surgery for that period of time. Take today's ambulatory surgery centers. You check in the morning at 7 o'clock in the morning. At 11 o'clock, you are in the hospital, in the operating theater, getting a hip replacement. By 6 o'clock back, you're basically back in moving. By 10 o'clock at night, you could be going home with help. Now you are at home. Yes, you are on painkillers, you are on a lot of things, but at the end of the day, you are being monitored. You can get that information back. And guess what? We have seen patients who are able to get back on their feet 3 times, 4 times faster. I'll give you a simple example. We had a patient about 3 weeks ago who was in one of our hospitals, a pediatric patient. There was a requirement for them to perform some sort of a surgery. The patient recovered within 3 days, 4 days. We thought the patient was going to be there for 6 weeks. We planned for that. But the patient went home. And guess what? We gave him the tools and technologies that he needs to provide the data back to us. He's awesome. That's the kind of capabilities that we brought together. And what has happened is that this crisis has made us become those catalysts for us to innovate and deliver those kinds of solutions. So, what we see for the future is the need for a person based care where every person can get care in their home using various capabilities. Number one. Number two, best care, better care for them because they are going to get recuperation faster or you get better health outcomes. And number three, the tools, technologies, and stuff that will happen are available here today. You go to Amazon, pick some of the stuff up, and use them. Be effective. Be effective for yourself. Be effective for the health system. And guess what happens? Access to care increases, cost of care goes down, and we met the triple aim. That is how we've been able to move this forward in a much faster, much better pace for us all together. That's where we see the healthcare industry transitioning, and this has been our conversation with CMMI and several folks with CMS and with with HHS. This is what we think will be the next stage of how we operate going forward. That concludes my presentation. I look for any questions that you might have.
That was excellent. Thank you, Shri. I see a question has come in. Can you hear me okay, Shri?
Yes.
Okay, so the first question is, how do you address the situations where the home is not a safe place? Or is there a better way to understand if home care is the best option? So I suppose there must be some type of assessment that's being done for the patient before they can be part of this program.
We go through an extensive process of trying
Hmm.
to identify which patients will be able to go through this program. And the reason why we do that is because we want to make sure that uh, there are, like I showed you, several factors have to be considered, right? So all of those factors have to be evaluated, realized, and then made sure that they've got the right level of people who can surround them with stuff with the ability to take care of them. They have the ability to support themselves. They got a strong internet connection because we need one of those. It's secure, right? It's not in the middle of some place where you can hack your network and the data all of a sudden goes out bizarre, right? So those are some of the factors we definitely take into consideration. For the patients that we have in hospital home today, we've shipped them with a tablet that has got all of these capabilities. And as long as the tablet connects securely to our environment, we'll be able to pull the data. That's where we are today. It is evolving. There is going to be additional work that we need to do, but it is there. It's coming, and it's something that we will look forward to moving forward on for us for the future.
That's great. And I think I remember seeing somewhere from HIMSS, one of the digital presentations last year from uh, the conference last in August. I think it
Yep.
was AT&T that they provide. It sounds like a connected care platform. They have like a package that they deliver to whoever's qualified for this program. Let's say if they have diabetes, they are given a package of all the different devices that are needed for them to monitor their blood sugar and everything. So is that an example of a vendor that is part of your
So
program?
yeah, we have what we call our bundle, an RPM
Mhm,
bundle. So
mhm.
in the RPM bundle, we have today in our environment today, we have a weigh scale, we have a glucometer, we have a blood pressure cuff, we have a thermometer, and then we have a tablet that takes all of that stuff, and we added a pulse ox from a COVID perspective. So we take all these, we package them together. They are pre-configured. So the tablet already has connectivity with all those devices. The tablet, all they have to do is plug in the tablet. It's got Wi-Fi capability, or it has got MiFi capability, one of the two. And then we ship them all to the patient's home. We don't even need to go to the patient's home. We just ship it over, right? And all they have to do is plug it in, switch it on, it all starts working because it's pre-configured to the patient. We already mapped the patients to the tablet. We mapped the patient back in because we got, our technical guys have got all the MAC addresses and all that stuff. They map all that stuff and we get that information back directly into the patient portal. So as soon as the data is plugged in, as soon as the devices are plugged in and the patient starts taking the measurements, vitals, it's uploaded immediately directly to the cloud, gets to us, which I can take. What we've done is because for a physician, you don't need every blood pressure reading, right? You only want blood pressure readings that are going what we call going south, right? In terms of the patient's not really getting better. So we look for a continuous levels of reading. So we have what we call a LCL and a UCL, and lower control limit and upper control limit. Take a systolic, diastolic, for example. So if we have a continuous pattern where we see the patient blood pressure not coming down, for example, then we have a video visit process immediately. We trigger that. So if the patient takes continuously, let's say he takes blood pressure every 2 hours, every 4 hours, and we see that the patient is pressure is not coming down. Okay, we know that something is going wrong. Maybe he's not taking the medication, right? So we have a video visit with the patient. Maybe his food intake was something, there was something wrong with the food intake, heavy salt. Okay, we have the conversation with the caregiver. Or then we have a conversation with the home health nurse who visits the person. So now, okay, I see that the patient is not recuperating. I'm going to try to see if I can increase the patient medication dosage. Right? Those are the things that we do. It's a complex process, but we have a workflow associated with it. And guess what? Once this become mainstream, this is how you will get care. This is how we will deliver care going forward. That's the mindset that we are going towards. So when we are building a brand new hospital, we're building a brand new $200 million hospital. And in that hospital, we're hoping that we will only get high acute patients admitted in the hospital.
Mhm.
That's where we are.
Great. So you had mentioned about discrete data that is being collected, let's say through the blood pressure machine. Ken is asking specifically about medical images. Was that available? Is it growing in importance? And how do you think about images and other unstructured clinical
So
data
we
documents?
so we don't get CTs, MRIs today, obviously at home. We don't have those capabilities, obviously, in the homes. But if you want to get an ultrasound, if you want to get some sort of a scope in, and if the caregiver is able to use the scope and get some information for us, great. We can use that information. Of course, there is going to be some precautions that they have to take. We might send a home health nurse to help them with that process, which is fine. But like I said, right? I mean, if you got to get a CT, you need to get. So we have the paramedics that can go down and bring the patient back to the hospital. Definitely available, but it's better than having the patient be in the hospital for 4 days because you need a CT fifth day after the surgery is done, right? So
Right.
that's where the difference lies.
Cool. And then another question is from Christina. What do you see is the largest barrier to advancing care at home? And what kind of conversations are happening around providing equity for those unable to afford basic health care?
Okay, great question. We are looking at this as a what I said is a long-term discussion, right? It's not going to change. The healthcare abilities for the average population that's below the poverty level in Medicare, Medicaid rather, is not going to change. However, we are seeing that there are opportunities where we can take this care and make it part of the mainstream process. Today, it's not mainstream. Today, we still have those what I would call care settings. And those care settings are bifurcated care settings with no interoperability, right? There are as little interoperability as possible unless you're part of a large IDN. So what we are looking at doing is we are taking the ability for bringing the data from the home to us in a way that makes sense to get started. Now, are we taking high acute patients and putting them at home? Not yet. Can we do that? Probably in the next 3 to 5 years, yes. But we are starting with a very robust, but at the same time, small population that will be able to take a level of care in their own homes with a way that makes sense for them because they have the right right, caregivers in the house. In some respects, that's not going to work because uh, it will be very difficult for the caregiver to take care of some very complicated patients. And we understand that, we realize that. But if we don't start somewhere, we'll never get there. So this was a way to get the process started and figuring things out. One of the barriers to advancement of this is reimbursement, right? There is a big, huge feeling about the fact that, am I going to get reimbursed for the care that if I provide the hospital in the house? Because I have to provide a similar, even though I don't use the same telemetry equipment, I still have to provide the same level of care. I still have to deliver the similar outcomes for my quality metrics, right? So that's for what we have seen is that, yes, those are some of those barriers that we will overcome. CMS has given us a waiver for bringing that together. So we can today bill CMS at rates as prescribed by CMS for hospital at home. We can do that today. We are hoping that that will get expanded to two, complex services; three, home-based services that includes food, transportation, social welfare, all of that stuff. And we are expecting that to expand to non-life-threatening emergencies as well. So we are thinking that if you look at our position around care, we are looking at expanding that. We will continue to expand that as part of the process, but it is going to take education. It is going to take change management, like we know, and it's also going to take additional innovation because not all devices are the same. Not all devices have been approved by the FDA. We've got devices from all over the world coming into the United States with a lot of things that we may or may not work the way we expect it to work. So all of those things are things that we are figuring it out. But we have a lot of people today that have figured out a lot of things. Mayo has got a great program around it as well. They talk about it, and Kaiser, similar situation. So we are seeing that happening, but is it there rampantly available today? No, not yet. Will it get there in the next 5 years, probably 7 years? Absolutely yes, because what we have seen with the benefit that the patient gets is phenomenal.
All right. Another question. Daniel is asking, what has been or will be your approach to closed loop referral network design to engage the community partners?
So in a closed loop referral design, when you're looking at that, um, the community partners become members of the care team. Today, the way our healthcare is structured is we've got the community physicians out there, we've got the large hospitals, we've got all of these independent, what I would call independent standing centers like labs, radiologies, all of that stuff. And today we don't have coordinated care. When I look at flip that, who are we providing care for? The patient. So if the patient says, I want to do this, and I want you guys to all come together, work together, and deliver the care that I need, then you're taking that care today that's either fee for service or value based care and transitioning that to a person based care. When that happens, when that transition happens, now you're thinking about all of those referrals, all of those community physicians that are out there are becoming part of your care. They have to become part of your care because they're all part of how you are provided care by the health system. And you have an obligation because you're paying for them. You have an obligation to make sure that happens. Now, are health plans in this yet? Yes, we have seen some health plans also willing to move down this path because they have seen better outcomes with patients. So there's lower cost, like we showed you what Geisinger did, and what has happened with what our own experiment has been, our own pilot has been, our own experience has been. That will translate into what we need to do going forward.
Great. So as we move forward toward this future of hospital at home, what kind of new roles are you seeing may come out of this?
Oh, great question. A more robust caregiver program, the ability for a caregiver to get trained on capabilities that they can do from their home, either help their mom, help dad. So there could be a situation where they do take a course
Mhm.
on taking care of moms at home or taking care of dad at home course, right? And they will teach you basic healthcare capabilities. Close to, I'm not saying a nurse, but close to being a quasi nurse, purely because now you become a caregiver. You become the nurse in the house. So that's one thing that I'm seeing to transitioning. The second thing that I'm also seeing is that a patient is now becoming more and more aware. So the patients now, apart from Googling stuff and trying to learn stuff that we all struggle with, um, we are seeing patients doing some research on themselves, the patients seeing, trying to understand, trying to learn, especially with a lot of focus groups, a lot of groups that have, we've created groups that have a patients with similar oncology type situation all coming together and sharing information among themselves. What became better for me? What became worse for me? Why I didn't do this? Why I did this? So they learn from each other. That knowledge, that capability is going to improve what they can do. And we are going to help as an industry, we will help people get that knowledge, get that capability. And the third thing is obviously we are seeing a change in the billing process. We're going to get billed for, and that the entire billing process will change if you're looking at how the services are being paid for. That is the other aspect of it. Now, are we going to change? Are we going to have all these settings change immediately? May not be, but we are seeing, like one of the daughters that we had in our hospital who wanted to take care of her mom. She learned how to operate these devices in about 3 days. She was with the mom in the hospital learning because she knew she was going to take mom home quickly. That we are beginning to see more and more and more. People are beginning to learn, people are beginning to understand, and people are not afraid to take care of things for their families. That's the other piece that we are seeing, and that is a big change. In the past, it was always something that I didn't want to know. You took care of my mom or dad. Now we're getting that happening.
Right.
One last thing, there is also a lot of people who are referring to each other as a big caregiver comfort group that is getting created for people who are taking care of moms and dads in the house. There's a caregiver comfort group. That piece is a phenomenal change in how people are learning from each other to take care of their kith and kin at home.
Mhm. With all these different moving pieces to get the program working and functional, you had mentioned you're working with CMMI, CMS, HHS. Is there a um, vision for creating a type of framework for other organizations that wish to stand this up? I know you're saying this is way out in the future, but is there a move towards that type of thing? Having a
Yes, the
framework
hospital
on. Mhm.
the hospital at home user group is creating that capability,
Okay.
is building that. If you go to hahusergroup.org, you will see it. You will see what are the organizations that are looking at it, how they are looking at it, what is
Mm.
a framework, what capabilities. And there are, I mean, you will see in the next year at HIMSS and the year after that at HIMSS, you will see a continuous movement towards this capability, purely because of the outcomes that we are seeing from patients.
Great. All right. Oh, another question popped in. So, if you were able to project forward 10 years from now, what percentage of patients currently in hospital would be at home?
About if we take our situation, about 45 to 60% of patients could actually be served in the home within a day or two after any surgery, any serious surgery.
Mm,
That is where we see our trajectory, our census, and where we see our census in terms of what we see in our build out for hospitals and beds. We are seeing that to be a trend just by looking at what we think, because we are able to look at, how our census goes on if I send 3 patients home or 4 patients home in a hospital home setting. So that model if we extrapolate, you will have quite a bit of patients that will be served at home. Within about 40 to 50% at the minimum will be a lower census in the population, but at the same time improving outcomes, which is the benefit.
Right. Okay. Any other questions? All right. So I'm just going to share my slide. Thank you, Shri, so much. This was so
Thank you.
informative. And
Thank you.
you mentioned that this topic would come again at the next HIMSS conference, which I believe is in March.
Yes.
So that will be something good to look forward to. In terms of our chapter coming up, our next event is going to take place in February. So if you're interested in joining that, please log into our site, and it's going to be a Women in IT series about female executives in healthcare. Patrice was also, just like with Shri, a speaker at the last Tim's event, so that will be exciting. And we always ask that at the end of all our presentations, if you could fill out a survey and let us know what you think and what you liked and what you'd like to see coming up so that we can make sure that we're presenting materials and content that's valuable to you as a member. And if, again, you want to join our chapter, please do so. Um, I want to thank Shri again for chatting with us. If you have any other questions, you can reach out to him via LinkedIn.